So good afternoon guys. We will continue our module of ECG concepts, P wave. We have already covered what is the basic things we have to see in P wave. In left atrial abnormalities, what are the findings? Today we will cover the remaining right atrial abnormality. Now again I will repeat the same concept here. When you are going to see the P wave or assess the P wave in ECG, the three things which you have to be very careful have to see. First, you have to see morphology in lead 2, then chest lead V1, and then the frontal axis. So we will cover the same on the same basics. We will see what is going to happen with the P wave in right atrial abnormality. Before starting, I have made a diagram here. You see, think resp causes 2. So it is just a reminder whenever you are going to get right atrial abnormality, you should also think the resp causes 2. We will cover as subsequently when we push forward in this module, but this is just a hint how to go for it. Now, what are the abnormalities of P wave you will find? First, you will find increased amplitude of the P wave in certain limb leads. Now, again, I have already described what are the main limb leads you have to see, 2 and V1. So in lead 2, what you will find, I have already made a diagram. You see the height of the P wave is increased. That is, we have already discussed in the first module, that is more than 0.25 millivolt or 2.5 mm in standardized leads. So I always write standardized ECG. This is very important. So increase in amplitude and increase in duration. This is first characteristic you see for the right atrial abnormality. Now you will also, there are some catch points here which I will just describe for you, that P wave duration may remain normal also. So don't just go if the P wave duration is not abnormal, it is normal within 110 millisecond. That means right atrial abnormality does not exist. It may exist. You have to see the amplitude. Then I have already, when I was describing P wave morphology in basic module, I was telling you it was smooth leads and there was a apex is smooth. It is not pointed. Here it is a pointed P wave. So pointed P wave, you have to think right atrial abnormality. And even if the voltage criteria is 0.25, but even if it is 0.2 millivolt, you need to think about a right atrial abnormality in ECG in clinical background. Sinus tachycardia, I have already told you that as the sinus tachycardia, the axis shift to the 10 to 15 degrees towards clockwise, which become more inclined with the lead 2. So you will going to get a tall and peak P wave in healthy individuals. But that is a healthy individual. Then P congenital, I will definitely cover this thing in next points when I cover other points also. But you need to know there is a P term called P congenital. Now it is generally aged with right ventricular overload. I will cover this thing separately. Then in COPD, you can have, this is a concept, you can have negative P wave in V1 lead, V1 and V2 chest lead. That is very important. In COPD patient, you may get V1 and V2 negative P wave. Why? Because in COPD, the diaphragm is lower and there was a downward displacement of the heart. So when you see, when there is a downward displacement of the lead V1 is looking towards the heart, and when heart goes down, it started looking towards the base of the heart. So then the P wave become, the vector become negative. So in COPD you can have negative P wave in V1, V2. P permeate, I will again explain it to you in coming up, but it is also an important term which you see in acute pulmonary embolism and status asthmaticus. There is something called P tricuspidal, that is a biatrial. I will again cover it at the end. So this is the first point and there is a catch points here. Now that I have put up that in chronic pulmonale or COPD, you have to see lead AVF. Why? As I already told in my previous module, that there is a rotation. Okay, there is axis rotation because of the right atrial dilation 10 to 15 degree, and in that way more than if it is 15 degree like in COPD or chronic pulmonale, the axis of the atria P wave become is more aligned to the AVF, which is 90 degrees. So now you got the answer. So it is going to be more prominent in AVF. So you got this question. Okay. Now what is the second criteria? Second criteria says increased amplitude of initial P wave deflection in lead V1. Now You all know now after this 2 module completion that in V1 there were 2 deflections of P wave. Initial is the positive, then there is a terminal component. Initial component shows right atrial enlargement. So there is an increased amplitude of initial P wave. Then how much? The question comes, how much? First you see the ECG, there is a pointed initial deflection and then it is taller and amplitude is going to be more than 0.15 millivolt. So it is 0.15 number you need to remember, and it is going to be pointed, and the leads going to be symmetrical. Normally it is not symmetrical. When you see, the more important thing is that it is going to have a very small negative deflection, or even if sometime if you find that V1 is not having negative deflection in P wave, it's also signify that the patient may have right atrial abnormality. So the duration of positive component, this is also very important, is more than or 0.4 millisecond. So what you have to remember in V1, you will see a taller positive deflection, pointed, symmetrical, okay, and there may be negative deflection is small or absent negative deflection, or duration of positive component will be 0.4. What is the voltage we have to see with the positive deflection? It is more than 0.15 millivolt. So now we are clear about the criteria in V1. Now the diagram you see, there is atrial dilation, how the vector changes more towards the V1, that's why it came more positive, and sometimes it becomes so enlarged that it can be completely negative in V2. Now third point, what you have to see, there is a potential tendency to right axis deviation of P wave in acquired heart disease. Now you see in the above diagram, if as the atria is getting enlarged, the axis is changing. It is going more towards the, if you see in the frontal, as the right atrium is in front, it is going more towards the right axis. It is, the angle is going to increase more beyond the 60 to 70 degree plus. So that is right axis deviation, and especially you have to see in emphysema patients, and basically it correlate with the lung disease. Now the concept has come, which I have left initially in catch points. What is P pulmonale? Now always guys remember, P pulmonale is whatever you have discovered with the P wave characteristic, okay, but it is a tall peak P wave with right axis deviation. So axis is going to be more than plus 60 to plus 90. So it also signifies that you can have a prominent P wave in PAVF. These are the basic concepts which you have to sketch. Now the fourth point, which is very important, a patient can have normal P wave axis with all the characteristics which we have discussed in V2, lead V1 and limb lead 2, with or there is a potential left axis deviation that signify congenital heart disease. So here the simple concept catchment: if a patient is having a right atrial enlargement because of the congenital heart disease, it is more likely having a left axis deviation of P wave, which is called P congenital. Similarly, if it is more pulmonary, then which is called P pulmonary, it is going to have a right axis deviation. So this is the causes for the congenital heart disease, pulmonary stenosis, TOF, and in Epstein anomaly you will get a marked left axis deviation. So you will have to, you can see prominent P wave in the leads which are seeing the left axis, that is lead 1, or even it can positive in lead AVL. It is so any tall P wave plus normal left axis in congenital heart disease is called P congenital. So you guys now know what is P congenital: P wave prominent with abnormality with left axis division. P wave abnormality with right axis division is P pulmonale. It is more in pulmonary causes. In congenital heart disease causes, it is P congenital. So now guys, you remember, always remember what is the difference between P congenital and P pulmonale. Now we go to the next point: rapid inscription of the negative component of P wave in lead V1, or early terminal P wave negativity in lead V1. So normally the P wave goes negative after 0.03 second. That is normal. That is, if you see, this is an inscription, the negative limb after going the positive. This is called inscription. So you guys got the what is inscription? This is the inscription. Rapid means fast and below the 0.03 second. Normally it is always normal. Intrinsic deflection duration is always more than 0.03 second. This duration, if you see, it is always 0.03 second more. But if it is going below or equal to 0.036 second normal second, it is suggestive of right atrial abnormality. So early terminal P wave negativity in lead V1. It is also one of the characteristic feature, but it is very uncommon, and it is very important. Why? You have to differentiate, because here you have a peaked, you see you have a peaked and you have a negative deflection more prominent. Ideally it is supposed to be the condition for left atrial abnormality. Now how will you differentiate this intrinsicoid duration? In left atrial abnormality, this intrinsicoid abnormality will not have a duration, will be more than 0.03 second, or it is going to be normal. Here it is below 0.03 second normal. It shows right atrial abnormality. Now we will also come to the one more fact which you need to know as a medicos, as a nurses, as a paramedics, that abnormalities of QRS complex has also to be checked when you are thinking of the right atrial abnormality. They help you and they make your diagnosis more correct, more sensitive. So what are the two main manifestations in right atrial abnormalities of QRS complex? That is, first is you will see QR complex in V1. So in V1 you will have a small q and a R complex prominent. That is more commonly seen in tricuspid insufficiency. Why this thing is happening, you have to understand. That is anatomical shift. If you see, I have made a diagram. I am not good at drawing, but you can understand. This is a simpler. So if you see, normally a patient is having when right ventricular hypertrophy. See, this is right ventricular hypertrophy. Normally it is very thin, right ventricular free wall. But you see here it is a hypertrophy, but atria is not dilated. In the next diagram, when there is V1 and V2. In next diagram, you see when right atria become dilated, it pushed the anatomically shifted, rotate the heart upwards. So your V1 got out of the line and V2 will come at this place. So there is a, basically it is the common thing is it is an anatomical shift which leads to this change. Now the second finding is diminution in the size of QRS deflection. Now it is very important because in many ECG, if you find that V1 is having a very small QRS complex, okay, and suddenly you find that in left sleeve V2 it is more than or equal to 3 times of V1, you have to think about right atrial abnormalities. So guys, that's all. I'm closing my right atrial abnormality module for the P wave. I hope you guys have understand. I have tried to make it very basic. I have tried to make it like what I understand. Please put up your questions, queries also, but this is basic, and please go again through it again and again. If you practice more, you will learn more. Thank you so much.